self-care is not selfish. It's actually the biggest part of showing love that you could offer to your family, your friends, and your community.
As women, we nurture and take care of the world. And so it's just so important to make your health, your self-care numero uno. So
get around people who are going where you want to go and who are where you want to be. And that's exactly what I did. I wanted to be in real estate, so I got around people who were doing things in real estate that I wanted to do.
So you might not be able to move things around or change what happened to you, but if you can change the way that you see it and how you're reacting to it, there's a way.
You just do what you have to do. There's no excuse. This morning, I knew that if I didn't get up at 4 in the morning and clear out my emails and do everything that I needed to do.
You don't want the government to dictate or a judge to dictate how your hard-earned sacrifice and wealth gets distributed to your family and your loved ones.
Our culture is embedded in American culture. There are people who come to America and engage in American culture, which is Black culture. So Juneteenth is really about Black culture, and it's about celebrating us, celebrating the different diasporas of Black people, even the dialects.
Felt. Let's make it
Hello, hello, hello. Happy Thursday, everybody. I hope you all are doing well. Look, I'm coming from another event. I still got all my stuff still on. I just ran in the door. I am really excited. I could not miss being on today to have this discussion because I have so many questions. But before I even get so started into that, happy November, everyone. We are in the second month of the last quarter of the year. And as a business owner, I'm always curious to hear and to see what you're doing with that. How are you preparing for the new year? I always say don't wait until the new year to kind of start figuring out what's next, but start planning right now. Start putting things in place and now. January is usually the slowest time for most businesses, and that is the biggest challenge. So I really appreciate you all for joining. My name is Athenia Rodney, CEO and founder of Juneteenth NYC. And we're really excited to have our speaker that we have on today. And he's going to do a presentation. He actually is coming back from a conversation that we had early on last month. And so this conversation today is going to be more in depth, touching on some things. So I hope that you came with some really good questions and some engagements, because like I said, I know I have some questions, right? So let me tell you who we have. Guiding us today in our conversation will be Dr. Krishna Vyas. He's an MD, PhD, MHS, a lot of letters after his name. So you know he spent some time doing some work and understanding his field. A world-class plastic reconstructive and aesthetic surgeon based in New York City. Dr. Vyas brings rare expertise in breast and nipple sensory nerve preservation and restoration. And like I said, I have some questions, because my question has always been, when people get breast reconstruction surgery, can they feel like how, like, what is life afterwards? What does that look like for those when you're involved in a relationship, you're married, I know that's a big stimulator for most people. So how does that, how do we change that? So I'm glad that we'll be hopefully talking about some of those things, right? He talks about what's possible in breast and body aesthetics. He'll be bridging surgical precision and emotional healing. Trained at the most prestigious institutions, Harvard, Mayo Clinic, Johns Hopkins, and Massachusetts General Hospital. Dr. Vyas has devoted his career to advancing the science of beauty, restoration, and regenerative medicine with over 200 peer-reviewed publications. That is amazing. Okay, I'm psychology major, and that is bar none. So we are very excited to have him here. Global leadership roles. I think he's traveling now as well and still able to jump on and connect with us. A lifelong commitment to mentorship and innovation. And that's what he's going to be doing here with us today. His mission is simple yet profound: to restore not just our bodies, but our lives. Please let's welcome Dr. Krishna Vyas to the stage. Welcome. Hello. How are you doing?
Great. Thank you so much for the invitation. I'm extremely excited to be here and very honored. And we had an amazing conversation last time. So sorry, I'm recovering from a slight head cold, and I'm at another meeting actually in Florida, in Boca Raton. So I'm super excited to be here. There's good lighting, so it's making me look less worse than I
Trust me, I understand. I woke up this morning, I took a whole bunch of Dayquil because my day was just full. So I totally understand where you're coming from, because I'm all in the headspace as well. But thank you so much for your time. And again, thank you for coming back. When we had you earlier this month, you were sharing so many great tidbits. It was like, no, this is like, we need a whole session just to talk and answer, get some questions answered.
Yeah. And I think the most important part is like really audience participation. At the end, there were so many great questions and things that I hear from patients every day as well. And things that we, as experts and consultants, we're here for the patient, just really to educate and inform and give guided decision-making. And then, obviously we work in different realms. A lot of it's very academic, rigid, clinical trials research, understanding things in depth, but also like transforming that information into something that's like palatable, that people understand what their risks are, what the benefits are, kind of what the goals of the procedure are. That's like really the critical part. The whole reason that we do all of this is really for patient care. And like, plastic surgery specifically is one of those fields that's very based on quality of life. Mm-hmm. So that's, really important. I think most of what I'll focus on is like mastectomy, breast sensation. So.
Okay, well, let's jump in, because I'm definitely ready. I got my papers, I got my pen, got my pen, so that we can get started. So we can bring up the presentation and
feel free to interject at any time, any questions that you have or comments. And yeah, so again, thank you so much for the invitation to be here. I'm based in New York City in Manhattan. Our office is actually moving from near Central Park to near Grand Central. So we focus a lot on breast surgery, and I'm part of the breast surgery group. So that includes, breast aesthetics, breast reconstruction, a lot of breast reductions, breast lifts, as well as gender affirming top surgery, which has its own implications for breast cancer risk before and after surgery. So most of what I'll talk about today is focusing on, and we can go to the next slide, restoring form and function after breast reconstruction. And so in plastic surgery, we really focus on how do things look good, but also like how do we improve quality of life and how do we continue to push boundaries to make our outcomes better. And that those outcomes could be, fewer complications or, ways to make things more efficient and recovery to be quicker. So a big focus of my practice is looking at sensory restoration in breast surgery, whether that is, breast reconstruction, mastectomies, gender affirming top surgery. Also knowing where these nerves are in all of these settings can help us identify them in all breast surgeries. For example, in breast reductions, you kind of know where these nerves are, where they go. And so I'm going to give a little bit of an overview of that today. Next slide. So this is a little bit about my training background. I was born and raised in Kentucky. I did my college, MD, and PhD there. And just for some background, my primary interest at the time during my PhD was the role of fat and fat transfer in breast cancer reconstruction. And so this sounds like so long ago, but probably, 15 years ago or whenever I was back in medical school, there was a big question about whether if we move fat from one place in the body through liposuction techniques, for example, a lot of people have stubborn fat in their belly, their flanks, other thighs somewhere. If we move that fat to a breast, is that safe? The concern at the time was that in a lab, if you grow the breast cancer cells with fat, it seemed that the fat had some sort of interaction with the cancer cells that may potentiate, their problems, their growth. So obviously that's not a good thing. We don't want to move fat to someplace and then, cause a problem. In addition, it can cause lumps, bumps, masses in the setting of a breast. Of course, that is always a concern because you don't, want to have unnecessary biopsies or imaging. So a big focus in my early academic career was exploring breast cancer safety and fat transfer. So, a lot of retrospective reviews, meta-analyses have been done on this topic since, and it shows, that fat is safe to perform in a breast cancer reconstructive setting, and it is a valuable adjunct that we have in breast aesthetics. Furthermore, fat grafting or fat transfer can help build the thickness or how thick a mastectomy flap is. I'm sure many of you know that after a mastectomy with no reconstruction, the chest is very flat. There can be divoted tethered scars. And so, fat transfer can actually help build very small amounts and make the skin a little thicker. So that was kind of my early training. And then I went to Hopkins in Baltimore and studied immunology and microbiology in a public health setting. So that was mostly focused on actually hand and face transplants and just the basic immunology of how do we make transplant immunology better.
I do have a question because you talked about and just for some of us who might not know and haven't experienced it, what's the difference between what is it, vasectomy and a bilateral transplant? I think is what you said.
Yeah. So, a mastectomy is basically removing the entire breast tissue. There are degrees of mastectomies. The mastectomies are performed by a breast oncologic surgeon. So that's your breast cancer surgeon. That's usually the first point of contact for the patient is, they have their primary care has done a workup, they have a lump, a bump of mass, nipple discharge, something that's concerning and not normal, rapid breast growth, for example, skin changes. They bring it to the attention of, their OBGYN or their primary care. Then typically, they get the workup in terms of imaging, mammograms, ultrasounds. They are referred to a breast cancer surgeon if they, have breast cancer or they need counseling, et cetera. And then typically at that point, the plastic surgeon is involved in the decision-making of like, how can we work together as a team with a breast cancer surgeon, with a radiation oncologist if radiation is indicated, with someone, if they need chemotherapy, there would be like a medical oncologist. The plastic surgeon is focused mostly on the reconstructive component. And that involves like what will be missing from the surgical resection, or once the breast surgeon is kind of done removing the breast, is that going to involve skin? Is that going to leave the nipple, or will they keep the nipple? And then just informing the patient at that point, even before, the mastectomy or the surgery, like, here's what your anticipated recovery could be like. Here's what, your options are for breast reconstruction. So that's kind of like the goal, for the plastic surgeon in this whole process. But it is a process. And then, I went to residency training in plastic surgery at Mayo Clinic in Minnesota. And that was a 6-year training program. We did thousands of breast reconstructions. And I'll go through a few details about like what, the options are during a mastectomy, or even after a mastectomy. And then I did 2 aesthetic surgery fellowships. So one was in Manhattan, mostly breast body focused. And one was at Harvard Mass General Hospital, where I then learned a technique that could improve breast sensation after mastectomies or during breast surgery. And so I just wanted to share kind of the timeline and trajectory of like, how did I get involved in this to begin with, and how the evolution of plastic surgery and breast aesthetics and reconstruction have evolved, because we'll touch on it. But, in the beginning, the goal was just like, we just need to cover the skin. We just need to like have a closed wound. That was the goal. Obviously, the primary goal is always, treat the cancer, do whatever you need to make sure that you're safe. That's always priority number one. But as a multidisciplinary team, we're able to help collaborate and make these decisions and say like, okay, like this is the plan. If you need radiation, this is what we know about breast sensation after radiation, for example. It will be, firm. There will be radiation changes. The skin will be very hard. You may lose most of your sensation. So I think over time, over the past probably 2 decades, there have been a lot of advancements in plastic surgery, because we're not focusing only on closing a wound anymore. We're focusing now more on like, how do we improve even more outcomes like sensation. So we can go to the next slide. So just wanted to, touch that obviously October is our focus month for Breast Cancer Awareness Month, but in the next slide, we'll show that really this is like, a year-long thing that we should be celebrating breast cancer screening, safety, awareness, kind of, throughout time. And this is a journey. So it's not just an isolated event, but it's super impactful to have this month that just celebrates breast cancer survivors, and then allows people to become more informed about prevention, early detection, reconstruction, recovery. And we can go to the next slide. So, these are kind of the main focuses in terms of breast cancer awareness. So number one, prevention. So, understanding what lifestyle factors really impact, the possibility of developing a breast cancer. There is kind of a foundational number, and it varies by geography, by risk factors such as age, estrogen exposure, family history. And so understanding like lifestyle, risk factors, genetic testing, for example, and then just becoming educated about this. Prevention is always, the most important, as it is in most in medicine. It's just understanding like, how do we reduce rates is like early detection, essentially. So that's point number 2. Early detection involves mammograms, and there are guidelines that suggest when should you have a mammogram, how frequently, what, age groups, what risk categories, and then, whether self-exams or clinical exams are indicated for screening. So, knowledge is power. Empowerment is number 3. So advocacy, respecting your body, and also just continuing education. The more you know, and the more, that you learn and ask questions, then it'll help you make a more empowered decision. I think that's really important to feel comfortable with whoever you're meeting with, to make sure that they have time to answer your questions, and then really go through, make sure that you feel informed before making a decision, because sometimes these things are, permanent alterations to the body. So any surgery we do, even if it's a breast implant, it will have lifelong impact. If it's a breast reduction, it will have lifelong impact. It could be good or for bad, but there are risks, to everything that we do. Survivorship. So what happens after the diagnosis? Are you getting the support that you need? And then as plastic surgeons, we try to focus on a lot of these factors, but the majority of what we do is reconstruction and recovery. So discussing with patients options after mastectomy, how we can help them heal and reduce complication rates, whether that's, stop smoking or reduce your body mass index or your weight in order to improve your outcomes or control your diabetes. Plastic surgery has this connotation at times that it's only focused on aesthetics, which is not true. After doing 2 aesthetic surgery fellowships, a lot of what we do is reconstruction and also empowering people to feel confident and just to feel like, they're in their body. And we'll talk about that a lot in terms of sensation in the upcoming slides. But the other important parts of, Breast Cancer Awareness Month is also equity, addressing disparities in access and outcomes. And then whether that's, the surgical care or even screening mammographies. And then, of course, like making sure that people feel supported throughout their journey. And next slide. So brief outline, we'll talk a little bit about breast anatomy and the assessment, like what's going through our minds whenever we're doing an exam. Breast reconstruction options. And then I'll touch a little bit on adjunct therapies, like donors can, provide their tissue, and those are, cadaveric donors, people who are organ donors. What happens to that tissue? And then, again, we'll talk about sensation. So next slide. So the breast is what seems to be a very simple structure that you see, on the outside. It's an external structure that consists of skin, a little layer of fat under the skin, and then there's actually breast tissue that has, early on, it tends to be a little bit more fibrous and firm. It's meant to produce milk. And then as you age, it can kind of become softer, more fatty. It can droop with time as well. So when we talk about the breast, and I point this out in the mirror to people when they come in for an exam, we're really talking about the borders of the breast. So it's not just the mound that you see that you're like, oh, well, my breast is here. It's actually, it goes all the way up basically to your clavicle or your collarbone here. It goes to your sternum, which is your breastbone here. It goes to your inframammary fold, which is the fold under the breast. Now, sometimes the breast falls below that fold, and of course, that's still the breast, but that was the original boundary of it. And then it goes over to a muscle called the latissimus. So I would ignore kind of like the complicated words on the slide than to suggest there are, areas of the chest deep to superficial, and then also like, medial to lateral. It's a broad structure. And the types of mastectomies that are offered, which I won't really, discuss today, but those can involve different degrees of muscle, or not the muscle, just the fascia, or not even that. Just, you can leave the nipple, you cannot leave the nipple. It really depends on the kind of anatomy of the tumor. So we'll go to the next slide here. Now, when you meet with a breast surgeon or a plastic surgeon, what they're looking at is the breast anatomy and the dimensions. So the standard dimensions that you see on the left are very, very kind of generic, standard, average metrics. They're not like, don't go home and measure and be like, okay, this is like my measurement. This is exactly what we need it to be. Because at the end of the day, it is an art. It involves a lot of creativity. But, in general, we're looking at some of those landmarks that I was talking about, the sternum or the breastbone, and the relationship of that to the nipple, and the relationship of the nipple to your breast fold. And so that kind of gives us an idea about where the nipple is relative to the breast mound. That relationship between the nipple and the breast fold, and where the nipple is on the breast mound, so the nipple is like the center of attention, is how we grade things in terms of sagging. And that word sagging has like a scientific word called ptosis, which is something that we think about for all types of breast surgery: reductions, breast lifts, breast implants and augmentations. And then, of course, like you want to make sure that your aesthetics look, fantastic. And the nipple should be like centered around whatever your reconstruction is. That's usually part of the goal. So we can go to the next slide here. So we'll talk about innervation as well. Innervation basically means that you have a bunch of nerves that are going to the breast mound, and they're all kind of going like highways into the center of the city, which is the nipple and the areola, or the dark skin around the nipple. And so there are nerves coming from above, there are nerves coming from the sides, and there are nerves coming from the middle. And they all have kind of like complex names, but essentially the most important ones are typically the lateral, so the ones on the side that are going toward the nipple. And so in this illustration, it's the person's extending their arm up like this. So they're the nerves that are coming out from along a few muscles, and going, then piercing the breast tissue and going toward the nipple. There is a lot of dense overlap in certain areas. And so that's kind of what this is intending to portray, is like kind of it's all going toward the nipple and the areola. So what we're trying to do in breast sensation surgery is try to preserve the ones that are, that supply the majority of the sensation to the nipple and the areola. We can go to the next slide. So the other thing that we're thinking about in surgery and before surgery in terms of planning and what your options are is the blood supply. So most of what we do in plastic surgery focuses on this. That includes the artery and the vein. And sometimes the tissue that we're moving or rearranging or conforming can have a blood supply that's very defined. It's like one artery is going in, one vein is coming out. So blood is going in, blood is coming out. This is what it's called. And like, that's how we design our tissue. That's how we know how much skin or bone or fat or muscle we can take without causing a problem, because you can't take beyond, really broadly beyond that territory, because it's just kind of, it's outside that territory and it may not survive. And then you have a wound, which of course is a problem and you have to babysit it, but also wounds can cause other problems like infections or exposure of critical structures. So this is a pervading principle throughout all of plastic surgery. But simplistically, like the blood supply to the breast is really based on a lot of vessels that come from the middle, and then some that come from deep, some that come from the side. And when we're thinking about options in terms of, maybe you want a breast reduction on one side and you want a breast cancer resection with reconstruction on the other side. So we're thinking about, okay, what's the blood supply to both sides, and then how can we make it look good and also for the nipple to survive. So you'll see during a mastectomy, and in this picture on the left, that during a mastectomy, you're cutting a lot of these structures. You're cutting and removing the breast tissue. You're removing a lot of these blood vessels. And so you have to kind of like be cognizant and aware that if you remove too many, or if you're going from a very large breast to a very, very small breast or no breast at all, that the nipple may not survive. And so not everyone is technically a candidate for a nipple sparing mastectomy, for example. Maybe the tumor is too close to the nipple, or maybe the blood supply is not good. So that's kind of the point of this slide, is like, it's complicated. This is what's going through our minds when we're thinking like, can we offer this as an option? We can go to the next slide here. So the journey after cancer is really, again, restoring confidence, identity, quality of life. We'll talk about the reconstructive process, whether you can use implants or your own tissue, and then whether this is an immediate or a delayed procedure. So really, there are two main paths. You can, well, probably three. You can do nothing. You could just have a flat closure with a mastectomy. You can have a reconstruction with implants or your own tissue. Both are beautiful and powerful options. And it really matters what matches your goals, your health, your lifestyle. And that's a conversation you should definitely have with, the surgeon who you would be working with. Sometimes when the skin is too thin during a mastectomy, it's hard to place an expander or an implant under the skin because it's just too thin and it's putting tension. It's becoming firm and it's not helping at all. So sometimes you can do this reconstruction at the same exact time as your breast surgeon is cutting out the tumor. Sometimes this has to be a delayed process. And so we can go to the next slide from here. But really what it comes down to is this illustration on the left is an individual who has something called a tissue expander. And during a mastectomy, an expander or a balloon, an inflatable balloon, can be inserted under the skin, and it simulates a breast mound. Now, it can either be above your pectoralis muscle, which is a muscle here, or below that muscle. So more commonly now, people are going above the muscle, and that's called a pre-pectoral position. The reason for that is that it helps with the breast aesthetics, and it also is way less painful. So imagine like stretching out your muscle like suddenly one day, it would be, really uncomfortable. So that's kind of an older technique. Now, sometimes if the skin is very thin, the mastectomy just looks black and blue and mottled, and it's not good. Like, we want to make sure that your safety is the number one thing. So the skin is going to survive. Then for you may delay and not put in that balloon at all, or you can put it in and just not put any air in it, or go below the muscle. So that's kind of the conversation when you're, discussing, am I going above or below? And then is this happening like now or later? Now this balloon you leave in and you come back into the clinic, and then someone will insert a needle through the skin and just inject basically water or saline into that expander. And it slowly increases the size of it over time. Usually once a week you can come in, it increases the size. And then once you're happy with the size, then, you kind of let it settle. Now, there are a lot of nuances that I won't get into specifically here, but things like chemotherapy or radiation can influence the timing of either filling the balloon or your next step in the surgical process. So the point of this is to really maintain a space so that your skin and your tissue aren't just like stuck down onto your chest. It's like it's a slow balloon that's kind of given a space so that the next step would be, okay, do I want an implant, which is a permanent? They're sort of the same, but the expander is not meant to be a permanent thing, and it's made of water. It feels very unnatural. It's tacked down. It's not mobile. It's not soft. So it's a temporary thing. But your decision then is like, okay, can I have a breast implant, which is, soft and pliable, usually made of silicone, but can be made of a saline as well. And it's meant to be a more permanent structure that's soft and pliable. Or do I want to use my own tissue? And so we can go to the next slide here. So if you decide to use an implant, then, implants can have problems. They're foreign bodies. They can get infected. They can form a tight scar ball. They can feel cold for some people. There are a lot of benefits. It's a much quicker surgery. It could be like an hour, for example. Some people are like, I don't really want to potentially have an implant problem over my lifetime. And if I'm young and I'm going to have to put, on average, 10 years is like the lifespan of an implant. It's possible it goes 20 years and there's no problem. It's possible that in 3 years it leaks or something like that. So some people are like, hey, maybe I want to use my own tissue. So this is an option that we'll talk about here. It's called autologous, which just means like auto, meaning like your own. But this is a very complex surgery, and it involves using your own tissue from one area of the body, most commonly the belly, but it could be from the butt or the thighs or the back. But it basically is like completely detaching tissue from one place and putting it in another place. So on the left, you'll see this one goes by a few names, but basically it's like what surgeons like to say, almost like a tummy tuck. It's not truly a tummy tuck, but what they're doing is they're removing the extra skin and fat along the lower belly and closing it, and then splitting that in half usually, and then using one half for one breast and one half for the other breast. So it's a very cool procedure. It's a very long surgery. There are risks of that as well, like blood clots to your heart or your lung, but there's a high patient satisfaction with this as well, because you don't have implants for your entire life. And you can also do nerve sensation work with these types of surgeries. It is a complex surgery in terms of like, typically involves multiple surgeons, long OR day, typically a few days in the hospital even. So, and you can get like hernias or bulges in your abdomen from surgeries like this too. So it's kind of robbing Peter to pay Paul in one sense. But it is an option, and outcomes are pretty good at specialized surgical centers. We can go to the next slide here. So hopefully that makes sense now that we've talked about placing the balloon or the expander as a temporary placeholder. You have the option of in 3 to 6 months, usually you can do an implant, or you can use your own tissue. There are adjunct tools that can also be used to improve outcomes. So one is at the time of the mastectomy, sometimes we have to wrap the expander or the balloon or the implant with basically a piece of skin or a piece of biologic product. It's off the shelf. Sometimes this is from a tissue donor that's been processed. And sometimes it's from just like a factory that has made like what you can think of as fabric, like a piece of cloth that is wrapped around either the expander or the implant. Now, why is that? I know it's very confusing, but at the time of the mastectomy, you have like a big pocket and it's just like an empty space. To place an implant in, it would just kind of like move around, sort of like a pinball. It'd be like, moving around too much. So the goal is like you want the breast to be a well-defined structure using those anatomic landmarks that we were talking about. So the goal is like we wrap it with one of these fabrics or a tissue matrix, and then we secure that with sutures or stitches on the inside, and that helps control the pocket. And the pocket, again, is that like defined space of the new breast mound. Now, remember, the implant is not a breast, and neither is your own belly tissue. It doesn't have the same function. It doesn't produce milk, for example, but it's a form and shape that is intended, to be there to help you feel whole again. And so another option is fat. So on the right, you can see, fat being injected into a breast. It's not quite that simple, but you can either use your own for that as well. Like say, hey, I don't like, my lower belly, or I don't like my flanks or my thighs. You can actually do liposuction, remove fat from those sites, and then move that fat to the breast mount to make it a little, more round. Or the limitation of this, a lot of people may say, well, why are we even bothering with an implant? Why are we even bothering with like moving, body parts around? The problem with fat transfer, which was the focus of my PhD as well, is that it's limited. You can only do so much at a time. So you're unlikely to build an entire cup size difference. You're going to maybe increase half a cup size. So it's very subtle. It's really meant for soft improvements. So as an example, the implant is sitting here. It could be you can have a breast augmentation, just cosmetic only. It could be a breast cancer reconstruction. Implant will just be like, if you're flat and you're thin and you have nothing on the upper chest, and then you just like, boom, put in an implant. It's like, there's no shelf. It's a very clear, distinct demarcation on the top, and it looks not natural. So fat can be used to kind of blend and contour and produce this ski slope so that it's a little more natural. 2 is now there are, off the shelf, ready to go options that are like, and again, tissue donation. Someone has donated processed fat, and it's been, cleared by regulatory bodies. It's been, tested for infectious disease, etc. And you have to inject little areas of fat. The, disadvantage is that's very expensive. The advantage is that you don't undergo a procedure or surgery at all. So it's nice. Both are kind of plagued by the problem of not all of it survives. So just say that you had it's almost like having this water bottle. If you have 500cc water bottle and you inject it all, half of it will just disappear because it won't all survive. And you can't overdo it to compensate, because then you get those lumps, bumps, masses, which again, in a breast setting is problematic for biopsies and other things. So, and then the final thing is nerves. So I'll touch on this in the next few slides as well, but yeah, we can proceed to the next one. So I'll talk about sensation preservation, and we can advance one more actually. So, sensation is kind of the next frontier of breast surgery and reconstruction. So we know the statistics, they're very high. 1 in 8 women will be diagnosed with breast cancer in her lifetime, and nearly 4 million breast cancer survivors in the United States. Nearly 80% of women will suffer from pain, numbness, or both after a breast cancer surgery. So those are really really statistics. So we can go to the next slide. This touches on what I touched on earlier. The evolution of breast cancer safety was, first, let's just take care of the cancer and get you healed. Now we've improved to okay, what do the aesthetics look like? And next is how do we make this even better? We listen to our patients. That's how we learn. That's how we grow and become better surgeons. Is you hear something and you're like, oh, this is we need to look into that. So that's actually how I learn and grow the most, is you go to meetings, obviously, you talk to people, you listen to your colleagues, but the patients are really who teach you the most, because you see your outcomes, you see what can be done better. And then, so there's now this shift toward restoring sensation to offer women the ability to look and feel better. And next slide. So why does sensation matter? This is kind of a busy slide, but basically, anecdotally, some people say the toughest thing about my post-mastectomy breast is that they have no sensation. Someone else, says, I had no idea there were so many everyday actions that could remind you of your loss. So this is a very impactful thing. I will say, like, and the reason I shared that trajectory of my training too is, different steps of training, you see different things. But I noticed in residency and also in fellowship, there were several patients who were years out, like decades, from a breast cancer resection. They had a mastectomy, they had a reconstruction, they had an implant, they're living life, they're like, everything's great. One day they just, they fall asleep with an ice pack on their chest or a heating pad. They don't feel that. They could have gotten a bug bite. Like, as annoying as that is, our body senses pain for a reason. It's a red flag signaling, being like, hey, something's going on, and just drawing your attention to it. So when we talk about sensation, we're not only talking about erogenous sensation, which is, of course, a major goal and a benefit in these cases, but also loss of protective sensation. So numbness can lead to burns from things like cooking or curling irons. It has an impact on our self-confidence and relationships. So it can have a negative impact on intimacy, body image. When I do these types of cases for, kind of gender patients who are going from female to male, for example, they're removing their breast, they also may lose sensation. And there are options to kind of restore sensation for their chest as well. And, a lot of the argument is like, well, why does it matter, like, if someone can feel their nipple or not feel their nipple? And I'm like, well, that's easy maybe for someone who has sensation to say, but there are problems of, like, you may not feel a hug, you may not feel a shirt on your skin. Like that to me is like so deeply moving and impactful, to like give the abilities back to someone, or at least preserve kind of what they have, is just like, I think, just the most powerful thing now that we have for breast reconstruction. So I think it's fantastic. But this numbness is a constant reminder also of the daily trauma that someone suffered from breast cancer, and it's a barrier to recovering for everything, like physically, emotionally, psychologically. So I think that this is an important topic to talk about for that reason. And the next slide will talk about why does a mastectomy result in a numb breast? So the nerves are like your body's electrical wiring system, and it sends signals between your body and your brain to allow you to feel and to move. During the surgery, of course, we talked about the breast tissues removed, sometimes skin, sometimes other things, but the nerves are cut. And you can't necessarily see every single nerve, because some of them are like, the size of an eyelash or smaller. So what we're trying to do in these surgeries is like try to preserve what we see. But nerves are cut during the mastectomy. That shuts down the signal between the brain and the body. And that can result in permanent numbness to everything: pain, temperature, vibration. In the next slide, we'll kind of talk about how does kind of a sensation restoration or resensation work. So nerves are cut, number one. Skin, nipple can be affected. We have the ability to use either donor nerves or tubes, or your own nerves or your own nerves, basically, to bridge the gap. So if something's cut here and something's cut here, you just provide a bridge between it. That nerve knows that it's been disrupted. It will slowly grow over time. Now, there are limitations in how far nerves can grow, because over time, they'll just like kind of shut down and give up. So you can't expect like a nerve to grow like a huge distance. But the goal of these types of procedures are like, okay, we can like either preserve the nerve from point A to point B, or if it's cut during the surgery for the cancer resection, which is again always number one priority, how can we bridge that gap? And so sometimes there's no gap. And in my top surgery patients for gender, I am not doing a cancer operation. So I'm able to actually dissect the entire nerve from the nipple all the way to where it's coming out. So it very translational application, which is also like the power of plastic surgery, is like nothing's ever the same. It's translational throughout. So something you learned in breast cancer could be applied to breast aesthetics, and that can be applied to like reconstruction. So you can actually dissect just like a cable coming out, a power cord from like, you know, your lamp to the wall. You just follow it the whole way, and that lamp should still work. So that's kind of the lamp being the nipple. Now, if that cord is cut because cancer was in the way and we just have to like get rid of it, you can still find the end of that nerve and just do a little bridge and connect it back to the lamp. So it will take time. The results are variable, but the goal is to restore sensation to the breast and, you know, to feel whole again. So next slide. So the ideal candidate for this type of surgery is someone who's going to, we can go to the next slide. Someone who's going to undergo an immediate or a delayed breast reconstruction after mastectomy. So I know that's a lot. There's a lot going on here, but essentially it means maybe you are a candidate. I think the best thing is just to talk to your breast surgeon and your plastic surgeon who work collaboratively at the time of the mastectomy to identify and preserve these nerves. That's the most critical part, I would say, of kind of this discussion is you may have a quote aesthetic closure with no reconstruction. And it's possible that we can still save your nerves and bridge them to the nipple. It's possible that at the time of that balloon going in, that we're able to identify the nerves. Now, remember, the balloon is now going to provide a bigger, you know, gap, basically. But if you see the end of a nerve or a cable and you bridge it with something, your own or a donor, and then you connect it to the nipple, it will take time, but it should restore some sensation. And that can be done whether you're doing the balloon, whether you're doing the implant. You can also go direct to implant, meaning like no balloon and just put in the implant. That's also an option, but it's it's an option for sensation as well. Fewer people are candidates for it, but if you're a perfect surgical candidate, it is an option too. And then also using your own tissue. So even if you're using your belly tissue or your back, you can connect those nerves to nearby nerves in the chest, or you know what was the breast. And so that's kind of like just powering, you know, point A to point B to kind of get the electricity going again. So it depends. Your candidacy really depends on your, you know, past history, for example, your medical history, surgical history, smoking, type of breast reconstruction that's planned, and the type of mastectomy that's planned. So I think it's important just to bring it up because not a lot of patients are aware of this as an option. And a lot of surgeons are not trained to do these types of cases because it's, you know, like I said, it's a fairly newer procedure. Like we have data for years, but by the time someone goes through training and then is in practice, you know, 5, 10, 15, 20 years, things change quickly. And it's something to ask about. And the answer could be like, I don't offer that. And that's totally fine. That's just, you know, something to discuss with them. But I think just discussing like, hey, is this like an option for me is something important just to know. So next slide. So we're almost done here. So post-op expectations. This is like one of the things I was talking about before. What questions like are people asking? So everyone's unique. Breast sensation's different for everyone before and after. So there is variability in the outcomes. Like some people with very large breasts to begin with are like, I've never felt my nipple sensation. So like maybe it's not important to them. Some people say like, that's the key to my satisfaction and I can't be happy without it. And so like, it's important to have those conversations. In an elective surgery, you're always like, okay, well, anytime we make any cut anywhere, it's possible you lose sensation. But there are ways that we can try to identify these nerves, save them, and help to improve them. And then the final point is that it takes time to heal and to grow. This is a very slow recovery process. It doesn't add, quote, recovery. It increases the length of surgery probably by about an hour or so, usually less. If you're doing both sides, for example, sometimes it's like 30 minutes for the total, just kind of depends. And then, the nerve can grow back up to really like 1.5 to 2 years. So just because at 6 months, you don't feel that much, it's the same with a lot of nerves all over the body. It doesn't mean that it won't grow back. With all this being said, there are mastectomy patients, there are gender top surgery patients who are flat, who have sensation even with no like nerve work done. So I don't want to push, the topic to say, oh, you must have it done. It's absolutely required. The way I counsel patients is it's a surgical tool that is meant to make your outcomes more predictable. And there are evidence-based published studies that compare groups of patients who have had a technique and who have not had a technique, and have found that those who had it in general had better sensory outcomes, better satisfaction, better patient-reported outcomes. And when you test the skin and things, they feel objectively better. So yeah, and we can go to the next slide. And that's just my contact information. If you, want to reach out, you have questions. I focus mostly on breast surgery. I do head to toe aesthetics as well, but the majority of my practice is like focused on breast. So thanks for listening, and I would be happy to answer any questions.
Wow, Dr. Vyas, wow. I took a whole bunch of notes, so I had a whole bunch of questions, and I'm like, yeah. So, because interest time, let me jump in. So, do you you talked about breastfeeding. So after doing reconstructive surgery, breastfeeding is absolutely not, would you say is not an option at all?
Right. Yeah. After mastectomy, all the breast tissues are removed. So no breastfeeding potential.
And so would you say, or because I've also heard this, does breastfeeding reduce the risk of breast cancer at all? Or is that just a thing that people say?
Well, yeah, it's a good question. So it's multifactorial, because really it comes down to all risk factors, like kind of assimilating things. I can say in a breast reduction surgery will reduce the risk of breast cancer in general, because there's less breast tissue, but it's not zero. So that's kind of like most of what we say in surgery is like nothing's zero, nothing's without zero risk. Like, but same thing. It's unlikely that someone would have, a complication like dying, for example, from a surgery, but it's a possibility crossing the street or, getting stung by a bumblebee or something. So
absolutely.
Yeah.
Oh, thank you. And then we have from Jezebel said, how do patients usually feel when they regain sensation after surgery? I guess, is it like a natural feeling, or is it, does it have the same kind of sensation? I would imagine is the question.
That's a great question. So it's altered. Usually it's not the same as before, but it's a new normal. So it takes time. It can be 1 to 2 years, usually post-operatively, that it can happen. But other things like radiation can cause worse widespread sensory deficits, and then something like chemotherapy probably doesn't help for sure, but it has maybe a less or more transient effect. But the early things to know, and I tell people, is you'll feel zaps and zings and static and weird kind of buzzing things. That's your nerve waking up. It's almost like when you touch the door handle and you're like, oh shoot, like it just lasts for like a second. And then it's like zings and zaps are the best way to describe it. But that can happen anywhere really from like 3 months to like 1.5 years or 2. So it's random things. It's not like painful. It's just like, oh, like there's something there. And so the degrees of like all those outcomes, sensation for pain, temperature, vibration, proprioception, 2-point discrimination, all those like objective metrics they're variable, but they're improved. So improved outcomes, but what the new normal is varies for each patient because their preoperative anatomy were all different. So their post-op may be as well.
Different. Got it. And we didn't touch on this, but does insurance pay for all of this, or is this something that people typically would have to pay out of pocket?
Great question. So there is an identifiable code within the billing process that identifies this as like a medical, necessity at times. It depends on, it's very, very complicated because it depends on your insurance company, the policy, the plan. But I've been successful in many times to get it covered. And then other times they're like, no, there's no evidence for it. And it was like, well, there is evidence because there's published data, but it's, some insurance companies are like, we don't consider something medically necessary. In the setting of breast cancer, usually those cases are covered by insurance, almost always 100% of the time for life. So that's fat grafting, fat transfer, breast cancer reconstruction in terms of an implant or all of those things. But it's always better, to check with the insurance company just to like make sure, especially for the gender top patients, for example, it's like they may consider the top surgery medically necessary, but they may not consider the nerve recovery. It goes by a few names like targeted nipple reinnervation or nipple neurotization. It's just called nipple because it's like that's where we're trying. Those are the big nerves that are going right toward it. But it's really meant also to prevent, and I talked about it a little bit, but it's meant to prevent numbness, chronic pain, phantom pain, and neuropathic symptoms. So not just about like, I discuss with the insurance is like, this isn't just about erogenous sensation. This is about like lifelong issues that are way beyond like just erogenous sensation. It's, you don't want like a phantom breast sensation or like chronic pain because the nerves are cut and now they're just live wires sparking.
Frantic, right? Just trying to figure out what to do. Yeah, as you were talking, it reminded me of like Mrs. Doubtfire, and I know this like the episode where he has these fake breasts and they're like on fire, and somebody's like, You're on fire, and he's like, oh my gosh, like I don't even realize. So just being able to understand and know that is a reality sometimes that could transpire. And then my last question was around hormonal changes, especially with females who have their menstrual, usually their breasts get engorged or things like that. Are there any kind of swelling or changes that still happen during those hormonal times of the month for a woman?
Like after reconstruction?
After reconstructive surgery, correct.
Typically, well, it depends on the type of reconstruction. So what I will tell people is any weight gain or any weight loss, because the hormones are usually influencing the fat, and like estrogen, for example, is kind of like with the fat, making the fat like bigger almost. So with a weight gain or estrogen kind of, the fat will get bigger. So if the fat came from the belly, for example, and then it's in the breast, if you gained a lot of weight, it's possible that reconstructive, belly breast is now bigger. But an implant won't like grow or shrink in terms of weight changes, but it's something to consider because for sure, if people are, a lot of people are on the GLP-1s, the Ozempics and Wegovys and all that sort of thing. So like if they lose a lot of weight, it will change the breast dynamics as well. And then, any kind of the breast will continue to change with time and gravity is the best way to describe it. Like same thing with a facelift or other procedures is like, if we reset the clock 10 years, then the clock continues to tick from that, like
that time point.
Yeah. So breast as well. Breast is subject to like time and gravity. So things will change, but a lot of people are much happier with their reconstructed breast than their native breast at times. So it's interesting. Yeah, it is interesting. We've, advanced so much that we're able to like give those sort of outcomes. It's like, oh my gosh, that's amazing. But Yeah. And then I guess the other thing to mention with the, insurance coverage of different things is that, it depends on the plans and the policies and like, will they cover the contralateral breast? Like if you're in a different country, they may not cover symmetry procedure. So you may have breast cancer on this side, but they won't cover any operation on the other side. So that's something to think about as well. Typically, it is covered here in the United States, but it depends on kind of like, where you are and your
Where you
plan.
are. Yeah. Well, thank you so much, Dr. Vyas. This was so, wow. This was a lot. This is some great information. I hope everyone in our community was able to take away. And please I'm going to put your information up with us one more time. If anyone, info@breastsurgerygroup.com. Like we said, he has a wealth of information, wealth of knowledge, and even I imagine even as just a second opinion, it would be great to just reach out to you as well to get feedback and thoughts on what can be done. So I know you probably have to run. I am going to put you backstage while I close us out. Thank you so much again for all of your time, your contributions, and just being able to share with the community. We are definitely going to replay this probably a couple more times during the Christmas break. Christmas break, just so that people can, when they're not as busy, can sit kind of so you might get some messages around that time. But thank you again. I really appreciate you. Any last words before you go?
No, I mean, it's my honor to like be here. I'm super, super excited. And this is like a fantastic organization. I'm so glad that you're able to, put people together and like educate. And I just want to thank you for everything that you do for the community and also like globally, really. So it's really fantastic. And I think this is an excellent forum. But yeah, again, thanks so much for inviting me.
You're welcome. Thank you. Have a great rest of your week and feel better. Feel better.
Yeah, thank you. A little bit of a head call, but I'm getting through. I'm in Florida now, so
go by the beach. The salt water helps. That's
exactly.
All right. Well, thank you again. Oh my gosh, I know we're a little over time, but thank you so much everyone for joining us. This was really amazing. I was blessed by the information that was shared and just being able to learn. I mean, it's not something that we talk about in our community, and unfortunately, it is something that affects a lot of us. As you saw, 1 in 8 females will have breast cancer over their lifetime. And that means that it has affected more people than we know. People are not talking about it. And we had a couple of weeks ago, some ladies who were on who have experienced it and gone through the process, and they shared some of their stories. So if you missed that, definitely go back and check that out because it was very heartwarming and very much in detail of like what society norms and how people feel when they go through this process. So being able to get back as close to normal as possible is really important. And I'm glad that insurances are taking that into effect and that it is being covered. So again, we thank you so much. We're going into the holiday season. If you are interested, we're going to be doing a Black Friday virtual session. We're going to be talking about Ghana for the month of December. We have some really great conversations that will be coming up. So definitely stay tuned, like, share, and follow us. We appreciate you. We hope you have a great one and enjoy your weekend, everyone. Bye.
So with the brand new album, and I'm talking hits.
Juneteenth Festival was a full celebration of freedom. A live donate today. Please like, share, and comment. Register now at juneteenth.ny.com. Thanks for watching. Please like, share, and comment. Register now at juneteenth.ny.com. Thanks for watching.